All right, so cardiac conduction. We talked about how blood flows through the heart. Now we're going to talk about how it's conducted through the heart, okay? So where does it always, an electrical impulse is what makes the heart contract, right? And where does it always start? The SA node, right? Oh, I guess I'll start here first. It's controlled by the autonomic nervous system. Your parasympathetic decreases the rate of your SA node. Your sympathetic increases the rate of your SA node. So if your SA node is the pacemaker of the heart, when your sympathetic system kicks into gear, it's going to increase that rate. When your parasympathetic kicks in, it's going to decrease that rate. And those balance each other out so that you have a normal heart rate. So during diastole, the atrium is contracting, the ventricles are relaxing and filling. So during diastole, that SA node is sending out a signal to the atrium to squeeze, and the ventricles are filling. During systole, the atrium is relaxed and the ventricles are squeezing. So everyone thinks diastole that your heart's at rest. It's filling, the ventricles are filling. So the heart's always doing something, right? That's why we have two heart sounds, lub dub, lub dub, lub dub, okay? So the SA node is what controls it. It's the pacemaker of the heart. And what does the heartbeat go? What's the normal heart rate? 60 to 100. 60 to 100. That's important to know because we are going to talk briefly about bradycardia. The SA node will send out that contraction to the AV node. Then it goes to the bundle of His. To the left and right bundle branches. So it comes down, bundle of His, left and right bundle branches, kind of curves off. And then to the Purkinje fibers. And I apparently have dyslexia. So when we're talking about a dysrhythmia, it's any disorder of impulse formation or conduction of the impulse or a combination of the two. So when I say disorder of impulse formation, the impulse to contract should always start at the SA node. That is what starts the heart. Oh, hold on one second. Okay, so if the impulse does not form in the SA node and forms somewhere else, you have a dysrhythmia. Or if it doesn't go, SA node, AV node, bundle branches, Purkinje fibers, if for some reason it skips, then you have a dysrhythmia. It always has to go that way. So you have lub, dub, right? This is diastole, systole, diastole, systole. Something's going on, and that's happening because of an electrical impulse, right? And the electrical impulse always has to start at the SA node, and it always has to follow the normal pathway. If it doesn't, then you have a dysrhythmia. All right, we're going to skip all the, okay. So this is what's going on. You don't have a slide for this. You don't have to write it down. It's just explaining what happens. You can write it on the back of the paper if you want. So polarized is the resting state. There is no electrical activity happening. This is a flat line on your EKG. Has everyone seen an EKG? Has anyone not seen an EKG? Okay, so everyone has seen it. So that flat line, that is when you're in a polarized state. There is no electrical activity happening. So this is a cell. These are the cells inside your heart. You have potassium and sodium inside the cell, and potassium and sodium outside of the cell. Higher amounts of potassium, lower amounts of sodium. That makes the inside of the cell negative compared to the outside of the cell. So you have a higher amount of potassium inside the cell than outside. You have a lower amount of sodium inside the cell than outside. That makes inside the cell negative. We are polarized at this point. Nothing is happening to the cell. It's just hanging out. So then the cell or the groups of cells become activated. They become stimulated. What stimulates them? What should stimulate them? What starts that impulse? The SA node, right? So the SA node should stimulate the cells and go, rev up, guys. We're about to get going. Okay? So we start the SA node stimulates that group of cells in the heart, and it becomes depolarized. So sodium moves rapidly into the cell. So I love to run races. I'm weird. I like 5Ks and 10Ks and half marathons. I've run like 20 half marathons, 1 marathon. So I know I don't look it, but I do. Okay? But I'm kind of, but when I run these races, I just go at my own pace and I'm doing my own thing. And then there's always my first Gasparilla race, my first half that I ever ran. I'm running and I'm going to finish, and I'm not horrible, but so I was finishing around the 2-hour mark. And so I'm coming up to the finish line and everyone starts going crazy. And I was like, I know. Right? I'm like, yeah, I got this. I ran a half. And then like a gust of wind, this man from like Ethiopia who was like this big goes flying past me because he just finished the marathon faster than I finished my half marathon, okay? So sodium is your Ethiopia man running into that cell as fast as he can, all right? He moves into that cell rapidly, and that's what causes the cell to become positive. And when we think of positive, we think of a contraction, okay? So we go from a polarized state, the SA node stimulates those cells, sodium rushes in, becoming positive, and that positive causes the contraction. Then you have poor Dr. D coming on in on potassium. I'm slowly going to get there to that finish line. The cell becomes repolarized because it stabilizes the cell. So sodium rushes in super fast, causes the contraction, Potassium slowly comes in, stabilizing it so that it comes back to a resting state. It has to keep going in this circle, in this order, for that contraction. So every time the heart contracts, this is what's happening. The SA node is stimulating the cells so that it contracts and then rests. Contracts and then rests. So you're like, well, why do I care about what's going on? Because if you understand this concept, you can understand reading an EKG. It makes it way easier to understand it. So, skipping all of that, I told you. Okay?
Are you going to go back to that other side?
Oh, you want me to go back? I'm so sorry. No, that's okay. I'm sorry. Go ahead. Yep. No, I'm sorry. I sometimes get ahead of myself. Just tell me when you guys are done.
Okay, sorry, I'm good.
You're good?
Yeah.
Okay. All right. So why again do I care what's going on? Because that's what's telling me what's happening on an EKG strip. So when I'm looking at this, anything that's flat, all these flat lines, what is that? That's polarized, right? That means nothing's happening. When I get depolarized, I have activity, right? So I have spikes on my EKG. That means that I have a contraction happening. Now, we have two parts of the heart. We have the atrium and the ventricle. So, which bumps represent which part of the heart? That's what we're going to talk about. So, the P wave represents atrial depolarization. So, when we think about the heart, we have like your tiny atrium and your big old ventricle, right? So, when the atrium gets depolarized and gets positive and contracts, it has just a small little blip. So that's number one, is the P wave. That's the atrial becoming depolarized and contracting. This is happening during diastole. Number two is the PR interval. So it is the entire impulse through the atrium. So it is from polarized to depolarization to repolarization. So the reason we care about that is because if all of a sudden in the middle of the cell, so if the SA node is conducting this electrical impulse, and it conducts it to start in the atrium, and all of a sudden a source from somewhere else tries to initiate an electrical impulse, the cells are already stimulated, right? What happens when you overstimulate something? You're going to go whack, right? It's going to just go crazy. So that's why we got to understand. So this whole thing is the cell becoming from polarized, depolarized, and repolarized. That's two. And I'm going to talk about those numbers in a second. You can write, so 0.12, less than 0.12 seconds for your P wave, 0.12 to 0.2 for your PR interval. Again, we're going to talk about those numbers in just a second. So you can write them down. So the ventricle is much longer, right? Or much bigger, I should say. So when it contracts, so when it depolarizes, unlike the atrium where it's got a little blip, when the ventricle depolarizes, it's like, I am the man. okay? It takes a big old jump. So the QRS, which is also less than 0.12, is the ventricle depolarization. That's when the ventricles are contracting during systole.
What causes that little dip?
It's just the part, it's going, again, it's starting polarized, and it's becoming depolarized, and then repolarization, which we're going to talk about those. So 4 is the ST segment. So this is QRS. Does everyone know the P, QRS, all that? Okay. So QRS, so ST segment should always be flat. That's the ventricle going from depolarization to repolarization. And the T wave is actually ventricular repolarization. So because the atrium, think of it as the atrium's kind of teeny and your ventricle's huge, that's why your PR interval is so kind of tiny. And then 6 is your whole QT interval. And that is the entire electrical impulse that's happening throughout the entire ventricle. So it's just longer. I'm going back. Don't freak. Don't freak. Don't freak. Don't freak. I'm sorry. Just let me know when you guys are ready. If do you have a question about what it says?
Is that like an arrow to that line of repolarization?
This one?
Yeah.
So it's this ST segment is when the ventricles are going from the depolarization, so contraction, and it's getting to the point where it's becoming repolarized.
Oh.
So it's going to repolarization.
Okay.
This is when the ventricle actually repolarizes, and this flat line is when it's polarized. Does that make sense? Number 6 is the entire QT interval. So you have QRS, which represents the actual contraction. You have ST segment, where it's going from contraction and trying to restabilize itself. And then, so then this is where it actually restabilizes, because it's got more, it's bigger, more electrical activity happening in the ventricle, right? Because what's the only impulse in the atrium? The SA node, right? What's in the ventricle? You got the AV node that's letting everything in. You've got the bundle of His, the bundle branches, the Purkinje fibers. There's a lot more electrical activity happening because there's a lot more in there. So that's why the segment is bigger. There's more going on. So this represents 6 is what's happening in the ventricles. 2 is what's happening in the atrium. Yes?
Where do they have the ST segment? It's the ST for
It's starting to go back. This is going to become important when you get to level 4 and you talk about MIs. Because what happens is you need the cell to become back to a polarized state to get stimulated again. You cannot stimulate a cell that's already stimulated. Otherwise, a dysrhythmia is going to occur. So you need your EKG to look like this. So if I know that there's something wrong with my P wave, I know that where's the problem? In the atrium. And I know if there's something wrong with my QRS or T, where's the problem? In the ventricles. And I know where it's happening because I know what's happening along that line.
What does it mean when they say there's like an AV blocker?
We're going to talk about it.
Okay.
And if not, we'll talk after.
So, the 3, that's ventricular repolarization and also depolarization?
No, 3 is the QRS.
Uh-huh.
That is ventricular depolarization. When a cell is depolarized, that is when that sodium rushes in, it becomes positive, and you have a contraction. Okay?
So where's the ventricle repolarization? Is that the ST?
So the ST is when it's getting ready to repolarize. The T wave is actual repolarization. Okay? Has everybody got that? So then it starts all over again. And the cells, you can't stimulate the ventricles before you stimulate the atrium. And you can't stimulate them in the middle of this process, or a dysrhythmia occurs. So let's look at, in general, back to this one. We're going to look at how to calculate the heart rate and determine the rhythm. Okay? So when there's these boxes on here, every strip will look like that. Most strips that you get, typical strips, are 6-second strips. How many seconds are in a minute? Okay, it's not a trick question, I promise. 60. So when trying to figure out heart rate or anything, we times everything by 10 to get, our number, okay? So a big box is 0.2 seconds because each one of those little boxes is 0.04. So 1, 2, 3, 4, 5. 5 times 0.04 gets me 0.2. Has everybody got that? No.
Yeah.
So when we're determining heart rate, you can actually count the number of big boxes to determine your heart rate. There's 2 different ways we can do it. They'll tell you that you can divide it by 1,500. I'm not counting all these tiny little boxes. That seems absurd. And if everyone's ever seen an EKG strip, they are teeny tiny. So I would focus on the big boxes. So if you have a regular rhythm, normal sinus rhythm, sinus bradycardia, even sinus tachycardia, you can count by counting the number of large squares in between your QRSs. So this right here, you count the number of large squares in between. So this one you have about 1, 2, 3.5, right? And then you would do 3.5 times 6 to get your rate. This one is not representative of 6 second. I'm going to show you one in just a second. So, I'm sorry. I was combining the 2. Take that back. So you do the 1, 2, 3.5. You do 300 divided by the number of large squares. And that is your rhythm. If you have an irregular rhythm, like what we're going to talk about, AFib, then you just count the tips. Count the QRSs. That's going to give you an estimate number. You could use, both methods are going to get you the answer.
I'm saying the picture that you provided.
Yeah, I'll show you this picture. I'm going to go back a second. So right here, let's calculate the rate. Is the R to R interval regular? Then we can do the 300 divided by the number. So right here, we would say that this rate is regular, right? So we have 1 big box, 2 big box, 3 big box, 4 big boxes, right? So what's 300 divided by 4? Get your calculators out. 75. 75. So then that is your rate. Your rate would be 75 beats per minute. Okay? That is going to be a little bit different. So if you have a regular rate, that's what you should count. That's how you should count your heart rate. Because if you did count the QRSs, 1, 2, 3 times 6, or times 10, what would you get? 30. That's a big difference, right? Yeah, it's probably not a 6-second, but yeah. But that's why I'm just using it as an example. You have to assume that if we give you a strip, or if anybody gives you a strip, it is a 6-second strip unless told otherwise, okay? So if you have a regular rhythm, you're going to count the big boxes in between, like we did. Did everyone see that?
One more time, please.
Yeah? So does it look regular? Like right here, there's 1, 2, 3, 4, right? Now let's look at the next one. 1, 2, 3, 4. So that's regular. There's 4 between each one. So we have a regular rate. So it's 300 divided by 4. When they say 1500 divided by the number, they're talking about if you're going to count 1, 2, 3, 4, 5. I'm not counting all those. You can just do the 300 divided by. Okay? Does that make sense? Okay. All right. So then you would get 75. If it's irregular, so do you see how like this one? If I look at this one, and here I have 1 big box, 2, 3, 4, 5. It was just over 5.5, and then now you have kind of a half. 1, 2, 3, 4, 5.5. That one's kind of the same. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5. This one's not quite 6. So you see how this one's irregular? Then what you would do is count the QRS. So then you would count here. 1, 2, 3, 4, 5. 5 times 10 equals 50. So your heart rate's 50. Does everyone get those two methods? So if it's regular, you are going to do 300 divided by the number of large boxes, which is this right here, the big thick numbers. And that's what's going to give you your rhythm. If it's irregular, you count the number of R waves in a 6-second strip and times it by 10. Is that good? Okay. I don't have diagrams for these because they don't really have diagrams. We're going to talk briefly about bradycardia versus tachycardia. So normal sinus rhythm, we said, is 60 to 100. So bradycardia is obviously below 60, 40 to 59 beats. But everything else is normal, okay? It has a P wave, a QRS, a T wave. It's, cells are being polarized and activating and all that other good stuff. And when they were talking about the numbers, the 0.12 to the 0.2, this is what they're talking about, those little boxes. That's when the little boxes come more into play. So you know that if my P is supposed to be 0.12, that's 3 boxes, right? So my P wave should be about 1, 2, 3 boxes. Does that work? Yes. 1, 2, 3. Does everyone see that? You guys see it over there? I know I'm not pointing. Okay. The QRS is same thing. It should be about 3 boxes. 1, 2, 3. Yep, that's it. So that's what they're talking about, normal intervals. When you guys get to 4, you're going to have this tucked in the back of your brain, because what they're going to do is show you more dysrhythmias. Your test 2 is way more dysrhythmias, and you're going to need this base, this foundation, because they're going to talk about things that prolong those, P wave and QRS, that make them greater than 0.12 to 0.2. Right now, we just want you to have a basic understanding of it as a foundation. So with bradycardia, clinical manifestations, with all dysrhythmias, anything with the heart, it's always about the cardiac output. When you have any kind of dysrhythmia, which is, that abnormal conduction, then you have decreased cardiac output. So if my heart is beating too slow, I'm not pushing out as much blood, right? So my cardiac output's low. If I'm beating too fast, then my ventricles can't fill with enough blood, so they're not pumping out that blood. So again, still my cardiac output is affected. So no matter what we deal with, it's cardiac output. So when we have low cardiac output, that means we have low oxygen going out to the tissues. So what am I going to be brain-wise? What symptoms am I going to see? Confusion, dizziness, lightheadedness. What about if I not have enough oxygen going to my lungs? What's going to happen? Perfusion. Short of breath, right? What about my skin? Cool, pale, all that stuff that we talked about with the congenital heart disease. So, and this can be normal. So again, I know it doesn't look like it, but I'm a runner. So my resting heart rate is about 49, 50 sometimes. Like my little thing will ding at me and say, when I'm just sitting watching TV, it's pretty low because I'm a runner and I run all the time. But if any of you came at me with some atropine or tried to wake me up, I'd be mad because I don't need treatment. I'm not having any symptoms of low cardiac output. We only need to treat it if it's symptomatic. So if I'm sitting on my couch and I'm not dizzy, I'm not short of breath, I'm not feeling sick, then I don't need to do anything because my cardiac output is okay. My demand and my supply are equal. It's when you become symptomatic that you have to treat. So if they have some kind of disease state, then I need to treat them. And the treatment we use for bradycardia, do you know what drug we give? Atropine, good. So atropine is what we give to increase the heart rate. Or if it's a chronic problem because of some kind of disease state, then they may have to put a pacemaker in and pace the heart and make it work at 60 beats per minute or whatever they need. And if there's something that's causing them to have a low heart rate, obviously stop it. If it's a drug that we're giving them that's causing them to have a low heart rate, stop giving them the drug. So when we talk about tachycardia, it's the exact opposite. So normal heart rate is 60 to 100. Anything greater than 100 is a tachycardia. And again, it's low cardiac output for a different reason. Bradycardia, you have plenty of volume. It's just not being pumped out fast enough. With tachycardia, you don't get enough volume because it's pumping too fast. So instead of doing lub, dub, it's like blah, 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 okay? It's just going too fast. It can't fill. So again, the same result happens. I still have low cardiac output. So I'm still going to have all those symptoms of dizziness and shortness of breath and pale, cool skin. Just a different reason. So, and again, with any tachycardia, we want to treat the cause. So if it's caffeine that's causing it, then we take away the caffeine. If it's a drug, we take away the drug. We may need to vagal them, bear down, make them push down. Or use a beta blocker, use a med to help with it. But until we treat the underlying cause, we have to treat the underlying cause in order for it to go away. So that's our main treatment with tachycardia. And again, it all relates back to that conduction because it all starts in that SA node, goes SA-AV bundle. So with a bradycardia, remember we said a dysrhythmia is any problem with the point of origin or the conduction through. So with bradycardia and tachycardia, it's not where it originates. These are originating in the SA node, and it's following its normal path. It's just following its normal path too slow or too fast. And both of them result in the low cardiac output. And you have to treat the cause in order for it to go away. There's something causing the conduction to slow down or go too fast. We good? Yay, nay?
Yeah.
You still awake? Come on, let's power through. All right. That's different than AFib. With AFib, it's not about conduction through, it's where it's originating from. So what should happen is that it should start in the SA node, cause the atrium to contract, go to the AV node, which is then going to cause the ventriculars to contract. When you have AFib, you have an ectopic source, meaning a source from somewhere else. So you have these little points of origin. You can have A flutter, which you'll learn about again in test 4, which is one source. But AFib, you have all these different sources. And they're all trying to conduct their own electrical impulses. So instead of the SA node being the pacemaker like it should be, you've got all these other sources coming at you. Right? So you've got this heart. I'm going to draw it a little bit better. Okay? You've got starting in the SA node, going. Oh, it doesn't want to draw my circle. To AV node, right? The little bundle branches, Purkinje's, okay? It should go ahead and start SAAV and go through. But what's happening, it's like the mom that's overloaded. She just got home from work and her husband wants to know when dinner's going to be on the table, and their child needs help with their homework, and work is calling because you forgot something, and the dry cleaner needs to be picked up, and the dog just had diarrhea on the floor, and your kid now is throwing up, and they're all hitting the AV node, right? Yeah. Right? And this happened. She can, right? Yeah. So all this is happening, and instead of the SA node getting to come home and just relaxing, everything is hitting the AV node, all these different electrical impulses. So if with that whole depolarization that we talked about, the cell gets stimulated, it contracts, it repolarizes, it becomes polarized, depolarized, contract. It's all nice, right? Well, now all we've got is, okay, it's not doing anything because it's being so stimulated that it can't go through that normal cycle. So the atrium is just quivering, okay? It is not contracting like it should. It's just sitting there quivering. Hold on. There's different types. Okay. It can begin and end spontaneously. It can last for several days. It can have an acute onset. It can happen post-op. Okay. It will come back. It will come back. It's okay.
See, you made us all quiver.
All right. So, because it is atrium, what do you think you're going to see messed up on your EKG? Not the Q wave.
The P wave.
The P wave, right? Because you have this happening, right? You have P, Q, R, S, T. This is all my ventricular stuff happening right here. There should be nothing wrong. I should see QRSs on that thing. What I'm not going to see is P waves. Because I didn't say that my ventricles aren't contracting, because what's happening is everything's hitting that AV node Once it hits the AV node, it goes through the ventricles and it contracts fine. It is the atrium that is quivering because it's getting overstimulated by all those ectopic sources. So I'm going to have this little quiver, right? I'm not going to really have P waves. They're just going to be chaotic. But then I'm going to have a normal QRS. And then chaotic P waves, and then a normal QRS. That's supposed to be a normal QRS. I'm not a great artist. So you can have an atrial rate of 350 to 600 because it's just sitting here quivering. It is not contracting. But your ventricular rate can be two different ways. If everything is hitting that AV node, you know, you've got the heart, you've got the SA and the AV and the bundle, and you've got all these ectopic sources that are all trying to originate the electrical impulse. If the AV node gets all those impulses and says, no, I'm only allowing 60 to 100 to come through, then you have AFib with a controlled ventricular rate. So your ventricular rate, so you're going to have normal heart should equal your atrial rate, and your ventricular rate should always be the same, right? When we were just calculating the heart rate, we were counting QRSs, which is truly ventricular, but there was a P wave for every QRS. So that atrium, the atrial rate equal the ventricular rate. Does that make sense? All right. But with this, with AFib, that's not the case. You have a atrial rate that does not equal your ventricular rate because your heart is not working together. So your atrium is just quivering and your ventricle is actually pumping, okay? And it's either going to be controlled by the AV node and pump at a normal 60 to 100 beats, or the AV node is going to be like, I give up, everyone just do whatever they want, and let in every electrical impulse, and then you're going to have AFib with RVR, rapid ventricular rate. So you're going to have a ventricular rate greater than 100. So those are terms you hear out in the hospital. And lots of things can cause this. Age, hypertension, coronary artery disease, smoking, alcohol, excessive caffeine.
What's the word after rapid?
Rapid response. So your ventricular rate will either be controlled or rapid. So, what do you think's happening to, again, whenever you talk about dysrhythmias, it's all about the cardiac output, right? So, what do you think's happening to your cardiac output? It's decreasing, right? Because the atrium is quivering. Is it really allowing blood to come down to the ventricles? No. So the blood that may be getting in a little bit, you know, when your valves open, some may leak in, but you're not getting that contraction to squeeze in. So your ventricles are pumping normal, but there's no blood in there to pump out. So your cardiac output is low. So you're going to have clinical manifestations. You're going to have an irregular pulse, right? Because that atrium and ventricle don't match. Probably have some tachycardia. Patient will tell you, I feel palpitations. They feel funny. They might be breathless because they have low cardiac output. Again, the dizziness, the hypotension, this is going to be significant for them. So when we talked about bradycardia and tachycardia, that they might have some clinical manifestations of low cardiac output, they just might be like, oh, I feel a little dizzy, but I'm walking around. These patients are like, I'm gonna pass out right now because they are super, blood is not getting to the brain. Blood is not getting to the lungs. So they're severely hypotensive. They're really dizzy. They're breathless. And the big problem is that atrium is just quivering. So, what is the blood doing? Is it going anywhere? No? So we got stasis. What happens when we get venostasis? What forms? Clots. Okay? So they're at really high risk for stroke or pulmonary embolism. Lightheadedness, weakness, confusion, chest pain, heart failure. All of this. It's all the kind of stuff we've talked about. Because we're not going to worry about it. So we treat it, again, we treat the underlying cause, right? Something's causing it. We got to control the heart rate, especially the ventricular rate. Because if we already have a limited amount of blood going into those ventricles, we don't want the ventricle beating so fast that there's no blood in there. Does that make sense? So we want to at least control the ventricular rate so that the blood that is in there is being pumped out effectively. Calcium channel blockers are the best for atrial dysrhythmias. But we can also use beta blockers, digoxin. The big thing is we need to prevent stroke, right? Because if I'm sitting here in AFib and my atrium's quivering and I have a thrombi forming and now I have a bunch of clots in my atrium and my ventricle's squeezing and I give a calcium channel blocker and my heart goes, oh good, thanks, lub-dub. Where are all those clots going? Everywhere. Okay? So before I really want to treat AFib, I want to make sure that they're on some kind of warfarin or aspirin or something. Coumadin. Because I don't want them to throw a clot because they're at really high risk for a stroke. They may need to be cardioverted. The cardioversion is going to say, okay, you're all trying to take over. Nope, the SA node's in charge. And cardioversion lets the SA node retake over conduction. Because again, remember, dysrhythmia is not only in, something wrong with the conduction pathway, but where it originates from. So by cardioverting, we allow the SA node to take back control. Ablation, that's like a last resort for AFib, because when we ablate someone, we go in there and we basically burn off the spots that are causing the electrical impulse. But with AFib, it works really well with A-flutter, because A-flutter you only have one other source. With AFib, you have so many sources that you'd be burning off like all day long. So we can use it if we're not controlled with medicines, but it's kind of a last resort.
I had a patient that was
Yep. Yep. So they'll go and cardiovert them. Now, if they... Oh, he's going to get the ablation?
He'd already been cardioverted.
Okay, yeah. Sometimes if they get, they've been on meds and they've cardioverted them and they still can't get control, they'll go in there and they'll try to ablate at least a couple of spots so that it's not as bad. But it's not your typical first-line treatment. You do the other things first. It might fix a couple of the problems, but they're probably not going to ablate everything. The patient's probably going to stay on some kind of medicine to continue to control it. It will for a little bit, but he'll probably still have to be on medicine because with AFib, remember there's a bunch of different sources that's causing it. And when we ablate, we only take away one source. So if he's got 50 sources, we've only taken away 1 or 2. So he's still got other sources that might cause the AFib. So he still might have to be on medications. Because they can't, ablation is basically burning off, whether it's cold or hot. And when we burn off, we're basically causing scar tissue in the heart, right? So we can't be burning off like the entire atrium. And then surgery, worst case. So we treat with diet, nutrition, exercise, avoiding the cause, you know, prevention type things that we talk about. No smoking. That's it. All right. Do you have any questions about any of that?